today is a continuity of what we already started about the contrast subject in radiology. Okay. We previously discussed the contrast reaction. Now we are approaching a more important to me, it is a clinical, practical, technical aspect of the contrast used in radiology department, which is the contrast injection and the protocols. The first lecture will be a generalized lecture, followed by specific organ imaging according to the priorities. Liver, pancreas, kidney, pulmonary, GI tract, whatever, or four-vessel angiogram. The subject is called contrast protocol and injections. Let us give this introduction, which I will again focus and talk more about it. The purpose of contrast enhanced CT, what is the purpose for giving contrast for a study, particularly in CT scan, is to find pathology by enhancing the contrast, which is the difference between a lesion and the normal surrounding structures. Normally we have a normal structure, that is, let's focus on the liver and pancreas. This structure is present in our body. There is evidence of a lesion. We are looking for, to see, to diagnose, to document. The job of the contrast is to make a difference in grade or attenuation between the organ and the lesion. This is what we are aiming for. Why? To see it. If there was homogeneity or identical contrast between the lesion and the organ, we can see the lesion. The job by these protocols and injection informations is to differentiate between the two. So sometimes the lesion will be either hypovascular compared to the normal tissue, and in this case the lesion will be or other hypervascular to the surrounding tissue in certain phases. The two options are for the lesion either to be isovascular, hypervascular, or hypovascular in relation to the organ. Each phase, now we will talk about the phases, is able to detect the lesion in this phase. And we will explain that, okay? So it is important to know in which phase CT scan should be performed, depending on the radiologist and technician knowledge about how to do the examination, and from my aspect, the clinical information about the pathology. The phases of enhancement are classified in two. Number one is non-enhanced CT scan, which is, we call it the control or pre-contrast study. The second is early arterial phase. The third is late arterial phase, hepatic or late portal phase. The late arterial phase is called early hepatic phase also. The nephrogenic phase and the delayed phase. These are the 6 known phases of contrast injection in CT scan. Okay? I will go in details for these phases. The non-enhanced CT scan phase, non-enhanced, no contrast given yet, is helpful in detecting calcification, fat in tumors, or fat even outside the tumors as a localized mass, fat stranding as seen in inflammation, which is the earliest time of inflammation around organs, like acute inflammation of appendicitis, diverticulitis, pancreatitis, or mental infarction. Most of these acute inflammations starts by changes in the surrounding fat of the organ. If we give contrast, we'll miss it. Without contrast, we can compare normal area with abnormal area and detect it. Okay? So this is the aim of the non-enhanced study, to compare this study with the post-contrast and to detect these items, calcification, fat and the tumors, and fat stranding. This is why we do the non-enhanced contrast study. This is the first phase representation. This is no contrast identified in the vessels. The organs have their primary density as without contrast, and the aim is to detect, for example, in the kidney for stones, in the kidney in ureters, or in the CVD, calcification in organs like liver or pancreas, it is important for diagnosis even. Calcification in pancreas can give me idea of chronicity of the illness. If I see calcification, I can say this is a chronic pathology or tumor-containing calcification, like the liver. Fat in the adrenal adenoma, it is very important. If I see the fat, I change my protocol. If I didn't see the fat, I continue with my protocol for contrast detection of a lesion. This is the first phase, non-enhanced contrast study. The second phase is early arterial phase. Early arterial phase, by definition, is the phase 15 to 20 seconds post injection or immediately post bolus tracking. If we are using bolus tracking, it is immediate. If we are using the injection as a primary source of timing, it is 15 to 20 seconds after the injection. This is the phase when the contrast is just present in the arteries, okay, of the imaging area, and has not yet enhanced the organ or soft tissues, okay? The contrast is only in the arteries. So from this aspect, you can recognize that this phase is very important for the angio studies. If I'm suspecting, let's say in the abdomen, aortic leak, aortic aneurysm, or leaking blood or blood escaping from vessels to organs, whatever, in this phase I can detect. Or in cases of very much hypervascular lesion that matches the early arterial phase, I can detect the lesion in this phase. Okay, the early arterial phase, in this example, this is demonstration. Vessels, organs are not enhancing, the vessel is only enhancing, and the detection is primarily for what is related to the artery. Dissection, aneurysm, arterial bleeding, etc. Okay, let's go to another phase, which is the late arterial phase. It is called the early portal or venous phase. This is 35 to 40 seconds after injection or 15 to 20 seconds bolus tracking. Forget about the bolus tracking. When we memorize the time from injection. So the non-enhanced is 0. The early arterial is 15 to 20 seconds. The late arterial is 35 to 40 seconds. This case is called the early venous portal phase because some blood is present in the portal artery but not complete opacification. And the aim of this study is that based on all structures that get their blood supply from the arteries will have more optimal and maximal enhancement in this phase. So at this phase, the organ that we are imaging is totally, maximally enhanced by the arteries that we evaluate in the early phase. So anything that is abnormal and supplied by the artery exclusively will appear in this case, okay? Late arterial phase, look what we are seeing. The blood is not, or the contrast is not just in the arteries. Some organs are enhancing, hyper intense here or hyper dense, and the artery that is opacified can, in this case, detect lesions that are primarily taking blood from the artery. The organ is not enhanced in the case of the liver. Why? The answer, because 80% of the liver contrast is coming from the portal, venous phase, so only 20% has its supply from the arteries. Regardless, the spleen is maximally enhanced, the kidney is maximally enhanced, pancreas is maximally enhanced. So in this phase particularly, we can detect lesions that are markedly hypervascular, particularly in the liver. Luckily, if it is exclusively hypervascular in other organs. It is very important phase for the practitioner to detect this type of lesions. Hypervascular lesion is detected in this phase that is totally supplied by the artery. Stomach, bowel, pancreas will enhance and we will show if there is a pathology. Detection of primarily the liver lesions. The liver lesions exclusively, which are arising from the liver itself, will enhance in this phase. The liver lesions, we mean that liver hepatocellular carcinoma, focal nodular hyperplasia, adenoma, adenocarcinoma of the pancreas, insulinoma, and bowel ischemia. This is particularly the use of this phase, okay? The third phase is the hepatic or late portal phase. This is one of the most important phases in the contrast injection. Timing is 70 to 80 seconds post-injection. Forget about the bolus tracking. Although hepatic phase is the most accurate term, most people use the term of late portal phase. We call the late arterial early portal phase. This case is called late portal phase. In this phase, what happened? The liver parenchyma totally enhances through its blood supply from the portal vein, and in this particular information, we know that if the lesion is hypovascular, we can see it in this phase. All the lesions that are hypovascular are detected in this phase, and mainly I am concerned with metastases. Metastases are most of the time hypovascular, so most of the hypovascular metastases or metastases generally appear in this phase. Why? Because I made a contrast between the liver, which is completely enhancing by the portal vein, and the lesion that is hypodense and not having any source of blood supply from the either portal or from the artery. So if I give you an example, you will see with me what I am talking about. This is the phase. Artery and vein are both opacified. You notice here the lesion that was supplied and visualized due to its exclusive arterial supply is vanishing because the liver enhances in the same time. We are losing its characterization. What happened? Here we can see another lesion which is hypovascular, no blood supply from it, so we can differentiate it from the liver. The liver is maximally enhanced due to its portal supply. The lesion is highlighted. So metastasis will appear immediately. Or we are losing contrast in the pancreas, we are losing contrast in the kidney, but already we diagnose our lesions in the primary early phases, and here the spleen is still enhancing because it is hyper and late excretion organ. Okay, hepatic parenchyma is detection of lesions, hypovascular liver lesions, mainly metastases, and other benign lesions like cyst abscesses will highlight during this phase. Okay? We note about this phase, if you are correctly imaging the late portal phase, you should see contrast in the hepatic veins. Add this information. If you couldn't see contrast, good contrast in the hepatic veins, you are not in the true late portal phase. Either you are early or you are late. Okay? Keep this note important for you. Arterial phase, contrast in the arteries only, minimal contrast in the portal vein. Early venous phase or late arterial phase, you can see vanishing contrast from the arteries, but maximum contrast in the portal vein. Late portal or venous phase, you can see maximal contrast in the hepatic veins, less in the portal vein, and markedly less in the arteries. Okay? You will remember this when you review it. Nephrogenic phase is exclusive for the kidney, but it is in the process of imaging. If we do it for the liver, we will not use it. But nephrogenic phase is the 100 cc second after the injection, and most of the kidney tumors and pathologies will appear in this phase. We might include it if we are interested in kidney evaluation. Okay? 100 second post-injection. Detection of renal cell carcinoma exclusively in this case. This is the liver, spleen, and we finished talking about them. This is the nephrogenic phase of the kidney, and easily we can see this lesion in the parenchyma of the kidney. Okay? This important phase is the delayed phase. Most of the technologists and radiologists do not understand this phase. Delayed phase, equilibrium phase. This phase, first I'll define it. It is 6 to 10 minutes post-injection of contrast in the liver particularly. And this phase is called the washout phase. Okay? Why washout? Because we are losing the contrast from all vascular structures, artery, vein, and hepatic, portal and hepatic veins. The remaining contrast is in the organ itself, and we also losing it. So let's continue talking. There is a washout of contrast in all abdominal structures except for fibrotic tissues, because fibrotic tissues retain contrast, poor washing of contrast, and will highlight in this phase. So, what is the benefit of the phase? Cholangiocarcinoma of the liver is fibrotic tumor. Scars in some of the tumors of the liver are seen well in this phase, and late washout tumors will be seen in this phase. Okay? This is the called delayed phase, equilibrium phase. We add it to the protocol of liver imaging. Enhancement of fibrotic lesions is enhanced in this phase, and still enhancement of the kidney and urinary aquatic system, but for the excretion and functional, not for the diagnosis. Detection of cholangiocarcinoma, fibrotic metastasis from mainly breast cancer, but this is can be detected early. Kidneys, transitional cell carcinoma. Why transitional cell carcinoma? Because it is in the collecting system. The collecting system in this phase is opacified, so we can see it as a filling defect. Okay? Why? Not for the nature of the transitional, but due to the presence of contrast in the collecting system. These are our phases. I hope you understand what are the phases, what is the aim of the phase, type of the phase, and the benefit of the phase for me and for the reporting doctor. This is an example, simple, we go through it. This is an early arterial contrast enhancement of the liver, 18 seconds. You notice that maximum contrast in the artery, no contrast in the vein, patchy minimal enhancement in the liver, right lobe. If we go to the late arterial phase, we discover that there are multiple big lesions in the right lobe. Why? Because these lesions are supplied by the arteries. The organ become enhancing. The organ have its maximum enhancement from the artery in the liver here. The lesion is hypervascular, so it takes from the artery. It showed early before the liver enhances, so we can detect it. If you have a good knowledge, clinical and as a technologist about what I am saying, easily you can manipulate these pathologies. Okay? Amount of contrast, there is a standard according to the weight. If the patient is less than 75 kilogram, the 100 cc is enough. Weight 70, 90, 120 cc is enough. More than 90, 150 cc is optimal. Why we are concerned always with the liver to give high contrast? Because we need large flow, large amount to follow the characteristic of the lesion. If we do it like in our next example here, if we give minimal contrast or minimal flow, I'll talk about this, the whole injection rate. In cases of suspecting early arterial lesions, hypervascular, we have to do the examination with 5 cc per second through a large gauge cannula. Remember this fact. 5 cc per second flow rate in a large cannula is identical for detecting early arterial hypervascular lesions. We will lose them if we give lesser amount of contrast, lesser flow, and lesser or smaller gauge of cannula. Okay? Let's go through the 3 to 4 cc cannula or flow rate in a 20 gauge cannula. And this is particularly useful for most of the organic pathologies. The upper abdomen portal base is well opacified in this phase. So let's summarize this point again because it has a certain point. We use the 5 cc injection rate and large cannula when we are looking for early or late arterial detection. So a kind of angio or kind of a hypervascular lesion, okay? If we are interested in later phases, portal late venous phase with a delayed phase, we use the smaller amount of flow rate and the smaller gauge of cannula. Clear? This is the conclusion of this point. I want to make it. In this case, look for 2.5 millisecond injection flow rate. You hardly see something in the liver. If you do it with 5 mil per second, you can easily detect this hypervascular lesion in the liver. Oral contrast, I will not focus too much, and we will comment later on. But look how the oral contrast, there are 2 types of oral contrast, negative and positive. What we mean by positive contrast? When we give iodine, water soluble iodine contrast. Negative when we give water. Please differentiate between the 2 terms, okay? Negative, when I ask you to do it is a negative oral contrast, this means water. Positive, it means contrast, okay? The disadvantage of positive contrast, it will fill the bowel with contrast, which is dense. So I will not be able to evaluate the wall. I can't see the wall. While in water, clearly I can differentiate the wall from the lumen, from the pathology, from the everything. The advantage of water is the evaluation of the wall. If I give a positive contrast, I will lose definition of the wall. So I will not evaluate ischemia. I will not evaluate inflammation. I just evaluate mechanical. If there is obstruction, if there is leakage, if there is any abnormality in the peristalsis, but not the tumor or wall evaluation. Okay? This is an example. Here, water, negative. You can see how clean and normal is the enhancement of the wall. Here is loss of enhancement, of course, due to the pathology and loss of opacification. Okay? Rectal contrast is one of the subjects that we use for examinations. Rectal contrast is used for what? When mean rectal, we are suspecting either perforation or anastomosis leak. Okay? We give the contrast through the rectum. Amount is 50 cc of non-ionic contrast, the water soluble, diluted in 7,500 ml contrast, total 800. The trick in this application is to give the contrast through a large caliber catheter, and immediately, once you deliver the contrast, once you think that the area of interest has been reached by the contrast, you do your imaging. If you delay your imaging, you will lose the pathology. The technical, when you are using the rectal contrast, the technical aspect of how to do it is very, very important. Of course, the doctor should be available with you in doing this examination. Okay? In cases of leakage, we'll give for you a specific lecture for how to deal with anastomosis leakage. It has a particular. Rectal contrast also is always accompanied with IV contrast. Why? Because suspicion in rectal contrast is perforation and anastomosis. It is a post-surgical or a pre-surgical. We have to know the viability of the organ. So we have to give IV contrast to see the enhancement of the wall. Is it viable or not viable? Thank you very much.